Hey folks, Scott Weingart here, and this is episode 2 of the One-to-One Nursing Podcast, the podcast on resuscitative nursing, where we attempt to increase the skill set of all resus nurses, whether they be in the ED, the floor, or the ICU. I am, as always, going to be joined by Candace King, my partner in this venture, in just a moment. But just a plea before we get started. You've noticed the first 2 episodes have been free, no paywall, and I want people to give feedback. That's why it is like that. Please, please let us know. Is the scope of what we're covering what you want? Is the depth what you want? Where are you in your career trajectory? And then how are you relating to what we're putting out there? Are you a new resus nurse and saying this is amazing? Are you an experienced resus nurse saying this is just too basic? I don't need this. And we will cater to all of the groups eventually if we have the knowledge of where we should be pitching this stuff to. So please, please go to EMCrit.org/contact and tell me, do you like it? Do you not like it? I'm so open to criticism in all things I do, but especially this. We don't know. We don't know what niche exactly we need to fill. So please listen to this episode and then get back to me whether you like it or not. All right, let's roll in. We're back for another episode of the One-to-One Nursing Podcast. How are you, Candace?
Oh, I'm lovely. Just had a little holiday, and now I'm relaxed, getting back to work soon. And yourself?
I am doing wonderfully as well. And Candace, we got the question going into this podcast, why are you leaving Candace blind as to what you guys are going to be talking about? It just doesn't seem fair. And Candace, I'm sure you share those sentiments. But what people don't know about Candace is if I told her ahead of time, she would easily spend like 6 hours preparing. And the stuff we're talking about when I don't let her prepare is stuff that is so ingrained in her knowledge base that I have no fear that there would be any, I don't know what to say. That's not going to happen. If there ever was, I would tell her ahead of time. But I know her, and I do not want her wasting 6 hours prepping for what she already knows like the back of her hand. So Candace, does that answer that question from the listener well enough?
I think so, but clearly the listener is on my side.
Oh, everyone's
like
please.
Everyone else in the world, they
side.
Support me.
We know how this works. As soon as you and I are doing something, everyone's going to be on your side.
Yeah, that's the right thing to do all the time.
Yeah, I mean, the subtitle for this podcast is Candy and the Grump. So I know where I stand.
That's because you don't listen. And my immediate answer is always no. Whatever you want to say. Candace, I want it. No.
Yep.
You didn't even let me finish.
I'm getting flashbacks of horrible traumatic memories here, but we'll leave that aside. We're going to get into the main topic we're going to talk about today, which is, and this came from a listener request, post-intubation pain, agitation, and delirium. That is the industry term PAD, but really, most ED resus nurses are just going to know this as post-intubation sedation, and that's what we're going to talk about today. So Candace, if you had to pick a pet peeve of post-intubation sedation, do you have one? Because I know I have one. I'll let you think about it for a second. I'll tell you mine, and then maybe you have one as well. My big pet peeve, which we're going to hit today, is when nurses take a perfectly sedated patient, they see the patient has hypotension, which is an expected sequelae of intubation, and they immediately turn off or turn down significantly the sedation that was doing perfectly for the patient, and it just drives me up a wall. Do you have a pet peeve?
I think that I don't like when people give a lot of drugs at one time and then just walk away and leave you standing there. And I think that if you're fine getting yourself out of whatever pickle you're going to get into, then you're fine. But I think that's it. Like when anesthesia sometimes comes and they said, I just gave a little bit of this, you never know what that means. So that kind of thing. And then 20 minutes later, I'm in a different pool of water than I was when we started.
Yeah.
So I think that's my biggest pet peeve.
I love it.
But I think for you, I totally see that, right? That they just turn it down rather than say, hey, do you want to give them a little something to raise their blood pressure rather than decrease their sedation?
Yeah.
Especially because you don't want to restrain people and you don't want to make them use unnecessary energy or be uncomfortable. So I agree. That's not really my practice.
All right, we will talk about that as well. All right, let's get into this. You have a patient that was just intubated, and now that I'm thinking about that, we're not even starting at that place, because in a great shop, at the time a doc is saying, hey, I think we're going to intubate this patient, here are my intubation meds, the question a good resus nurse would be asking at this point is, okay, doc, what do you want for your post-intubation sedation as well? I mean, that would be a mark of true resus nursing excellence, because you don't want to find that information out after the patient's intubated. You want to find that information beforehand so that you could actually have the stuff ready for the second the patient gets intubated. So, Candace, are your resus nurses trained to be proactive in that regard?
Yes. And I think that's because we've created that checklist, right? Which is an opportunity for you to get whatever's not in the room. I guess my philosophy is if you have to prepare, then you're not prepared. Like you should kind of always be prepared, but it's hard to do that when it comes to narcotics, right? Especially if you don't have like a mini Pyxis or QB or whatever you're using in your recess room. You have to leave the room to get the meds, right? But you don't want to continuously leave the room because when you do that, you one, leave your partner there alone. And two, you miss parts of things and sometimes small things are not ones you want to miss. So yes, they do that off of a checklist, right? And part of the checklist is to make sure we're prepared to have the best first pass success the first time and plans if that doesn't work out, but usually includes post-sedation meds, like whatever,
absolutely.
Pain and sedation.
That's exactly right. And that's what I've tried to bring to all the shops I've been at. And so if you have a doc coming to you and saying, hey, I need to intubate this patient right now, then the way to play is grab the intubation meds and ask one of your partners or colleagues to grab the post-intubation sedation meds. But most of the time we're intubating, it's like, we're going to intubate this guy, whenever we get everything together. And that one, you could just, one nurse could just grab all of those meds at once. And we actually have time to get those orders in that circumstance and just put in your post-intubation sedation orders now so that the nurse doesn't have to withdraw those meds and then come back later to actually have them linked to the proper patient. All right, Candace, let's assume that was done and you have a new doc. Maybe it's an intern who's actually talking to you. They won't be intubating the patient alone, but they come to you to say, hey, the attending said we're going to intubate this patient. And they just ask for propofol. What would be the next thing that you would urge them to think about?
Do you want to give some Dilaudid?
So there you go. And we're going to try as much as possible to stick with generic names, and we're both going to slip, so we'll catch each other. You're saying hydromorphone, and where you're at is a hydromorphone shop. And I think each place in their resus area, and perhaps in the ED in general, should just decide, are we a morphine shop or a hydromorphone shop? Both of them are fine, but you shouldn't be switching back and forth, because then you get the possibility of errors where it's like, if you're a morphine-only shop and then one doc decides, I'm going hydromorphone, and they say, I want 3 milligrams, and that's the nurse is like, who's not familiar with that is like, okay, I guess that sounds okay. And it's not okay, unless that patient's a cancer patient who's on massive doses of opioids, but it doesn't sound scary. So you should just stick with one opioid. They're both fine. My buddy Sergey Motov would tell you being a morphine shop may be better because pain seekers don't really like morphine as much. It doesn't have that high that comes with hydromorphone. But we, I think, are both on the page of like, we're not using this inappropriately. We're not using hydromorphone for chronic pain seekers. We're using it for patients who have acute pain, or in this case, post-intubation sedation. Hydromorphone's fine. Okay, so you're going to ask for some form of pain medication and sedation at the same time. And now, we mentioned propofol, and I think that's the right choice for at least the initial med in every emergency department resus. Dexmedetomidine, which we'll talk about a little, is a great medication. It's not a great startup medication for a patient who needs immediate post-intubation sedation. Is that your feeling as well, Candace?
Yeah, I think when I first started using it, though, I had a big fear, right? Because I watched somebody become bradycardic and then die.
Yeah.
So I had like a lot of hesitation. I know you and I have had arguments about that before, but I was like, ooh, I don't know if I want to do that. So I think that propofol is like really the better starting point.
Yeah, even if I knew I wanted a patient on dexmedetomidine, immediately post-intubation, I'd want them on propofol. It just works so quickly. We could get it titrated. We could get the patient happy and comfortable, and then we could move to dexmedetomidine in this slow, up titration of the dex, down titration of the propofol, and it's a much safer, easier way to go. You can get patients rapidly sedated with dex with a bolus, and that's going to have massive hemodynamic consequences that you don't want on a critically ill patient. So it's not worth it. I don't use boluses on any patient with dex anymore, except for maybe a rock-solid, stable patient that I was doing it as a procedural sedation for something like a chest tube. And their hemodynamics are great, maybe. But even in that circumstance, I'm like, is this really worth it? It just seems a better move to titrate up an infusion rather than giving the bolus, which we know is associated with hemodynamic consequence.
Yeah, I think that's the consistent workflow now. I mean, in the beginning, people were bolusing and we saw a tremendous amount of, negative effects. And now we don't really do that anymore. I think there's a place for it. I just don't know that the place for that is your initial sedation medication.
There you go. All right, so you got a request for propofol and hydromorphone from this intern. You're getting it with the intubation meds. You have those at the bedside. The propofol is in a pump already, or it's being put into a pump as the patient's being intubated, so it's good to go. Hydromorphone drawn up, properly labeled. We are in a fantastic place. And now the doc intubates the patient successfully. Yay, everyone in the room's happy. And we immediately want to start up the sedation meds because we know from a couple of studies that in emergency medicine, the patients are at risk of paralysis awareness, especially if rocuronium was the medication chosen. And it is because the patient looks happy, right? Because they're not moving around, they're not complaining because they're paralyzed. And yet the induction meds can wear off. And now ketamine is going to take longer than something like etomidate or propofol. But even in a ketamine circumstance, if they got the rock, you don't know when that ketamine ends. So I would much rather have a little extra propofol on board, even though the ketamine is still there, than the alternative, which is the ketamine wears off, and now we have to wait for the rock to wear off for the patient to let us know that they have been aware and paralyzed for 15 minutes. That's a never situation in mind. And the only way a paralyzed patient without sedation could really express what's going on, besides vital sign changes, they'll get tachycardic, they'll get hypertensive, is by crying, by having tears running down their face. And when I walk into a new shift and see an intubated patient with tears streaming down their cheeks and the patient's paralyzed, it's one of the few times I truly get angry in emergency critical care. So don't let that happen to you. Don't let that happen to your patients.
Yeah, I mean, I think that sometimes we don't do a great job at that, right? Because there needs to be a balance between the two, and you can't ask the person, "Are you in pain?" Right. I agree. I'd rather give a little bit more upfront than risk them, just being paralyzed and not sedated and not have anything for pain. Because I've been intubated before, and it's not super comfortable. I was awake, so I remember. And I would never want to do that to somebody else.
Absolutely right. Now, the doses we use of propofol for a patient that is accessible, they're usually in, I don't know, the 20 to 40 range for patients that don't have some innate resistance. Does that sound right to you, Candace?
Yeah.
Yeah. I would like people to, until the rock has worn off, go much higher on your propofol doses. And this might seem scary to a lot of people. And the thing to keep in mind is the younger you are, the more propofol you need. Kiddies need very, very high doses of propofol. And as you get to, your geriatric ages, you could get by with just a whiff. But if you take the average aged person, like in their 40s or 50s, 20 while paralyzed is not enough. And you should really push higher. Ideally, we talk about going beyond 50 in those patients, maybe in the 80 range as a, empiric thing. It seems scary. So, Candace, if I ordered as the doc after intubation 100 or 80 of propofol, would the nurses at your shop look at them with dismay and think they're crazy, or would they be okay with that?
100, I don't think they'd be okay with. 80, I think they'd be fine with.
All right. A lot of shops, they wouldn't even be okay with the 80. 50 seems to be this arbitrary cutoff in emergency medicine. And
yeah, but who made that?
I don't know. I think where it comes from is long-term.
30 Levophed is the max.
Yeah,
true.
We'll get to that on another show. So I think it comes from the literature on propofol-related infusion syndrome. Where long-term being over 50 is a problem, I think that's where it emerged from, but that has nothing to do with the short term. Anesthesia, when they're in the operating room, runs at much higher doses for their 4 hours of an operation. And I think early on in the ED course, you shouldn't worry about it so much. Long term, yeah, I don't want a patient on greater than 50 if I could avoid it. But for this, during the rock, for those 40 to 60 minutes, and remember, we're using big doses of rocuronium in emergency medicine.
Right.
It lasts for probably around an hour. And if the patient's metabolism is off, it may last even longer. So that's a short-term use of these high doses of propofol. In places that are scared, what I recommend, Candace, I'm curious to hear what you think, and I hate benzodiazepines as your long-term sedation strategy. You should not have midazolam drips as your sedation. We know this is associated with longer times to extubation, with increased delirium. Don't do it. But in this circumstance, giving 2 to 4 milligrams of midazolam in addition to your propofol for that patient during their rocuronium period will get you by with 50 of prop quite nicely. And then that's it. It's a one-time thing. It's going to cause some increased sedation, but more importantly, it's going to cause amnesia. And so even if the patient had some degree of awareness, this hazy awareness on their 50 of propofol, they're not going to remember it, which is where the trauma comes from, is this long-term remembrance of this traumatic activity. Candace, what do you think of that?
I think that makes sense. And I don't think that we use midaz as much as we probably could in that time period, but certainly it's an option. I think I would probably go with the higher dose of propofol myself, just because it's there, right? I don't need to get something else or bring something else, right? So then I'm bringing like 3, 4 narcs with me versus just bringing 2. The other thing is some places lock up prop. Have you seen that? Like have that clear lockbox? Like we don't do that. But I think that takes some time. So then you're doing all of this stuff and now going to get another drug. So for me, I agree that the short-term utilization of a drug very different than 3, 4 days worth of a drug. And you need to kind of see how the person fares in the process.
Candace, the next thing I want to mention is you need a sedation scale. And I have been to EDs where they're just like titrating, with the wind, whatever their heart tells them. And that doesn't allow good communication between the doc and the nurse. Now, are you folks still using the Richmond Agitation and Sedation Scale?
Yes.
Okay.
Yes.
That's the one I like.
Yeah, we use that pretty consistently. We only use it when the patient's on long-term meds. So meaning, if you're just doing a quick procedural sedation, we don't use it. But certainly if you're intubated on some kind of sedation, we do.
Now, that allows the doc and the nurse to say, here's the desired range of sedation we want. Otherwise, it's very difficult to communicate. And I guess if I had to communicate it without a scale, I want a patient who is sleepy but arousable in most clinical circumstances, which means they're not so deep that I cannot get that patient to open their eyes, but I want them sleeping most of the time. Sleepy but arousable is usually what I want. In some patients, I'll have a lighter sedation desire. In some patients, I'll have a much deeper one, a patient with ICP issues, for instance. But for most patients, sleepy but arousable gets me everything I want. It means they're chill. They're not miserable with all the cacophony of the emergency department around them. But if I need to say, are you in pain? They could actually open their eyes and they could nod. That's ideal. Now, I see many EDs where they are sending these patients deep, deep down into the florid areas of coma. And we could talk about why that is when we get to the restraint discussion in just a bit. But is that really the place that you're going for as well? That would be a RASS, Richmond Agitation Sedation Scale, of -1 or -2. That means with voice, the patient is opening their eyes.
Yeah, I think we stick to kind of a -1.
Okay, yeah, -1 sounds delightful.
Pretty routine.
Yep. And that means the patient will actually maintain eye contact for greater than 10 seconds after being roused by voice. And that's really helpful because now you could say, are you in pain? Which brings us to the next thing, which is if you send a patient deep, deep down, first of all, you're not going to be able to know if the patient's in pain. And second of all, you're going to have a lot of hemodynamic consequences. If you don't have adequate pain meds on board and you're just using sedation alone to get a patient who's willing to tolerate that horrible feeling of a tube in the back of their throat, yes, you're going to have to use a lot more propofol. So how do you folks manage this balance? This is the question we get all the time. How do I know if they need more sedation versus more pain?
I think that it's a global picture, right? So it's being attentive to changes in their hemodynamic vital signs as well as their own movements. But I think that, you need to do the whole environmental stimuli reduction. Like you don't need the monitor alarms and the pump alarms to be on 10. It would be nice if they were lowered, not to a level that you can't hear them, but one that is responsive for the patient. Shut the lights down. I think that once you get all that stuff together, and then you leave them at a -1, -2. I guess if you're used to having patients more deeply sedated, then a -1's going to make you feel a little uncomfortable, right? So then you could go to a -2. I think that you will be able to develop that if the patient has changes that are just enough to make you say, oh, what is that? Like, why did they have that bump in heart rate? Or they seem to be moving around a little bit more, that's when you need to decide that you want to give more pain medication. I don't think always the answer is to titrate up their propofol. I think sometimes you need to think about the picture globally. How would you feel if you were in that state? You'd want to have a combination of both.
Absolutely. And, I tell this anecdote all the time, which is you have a patient who is completely normal. You actually spoke to them about the fact that they're going to get intubated. They completely understand. You have a rational patient. And then after intubation, you have a raving maniac. And people are like, oh, they need more sedation. No, they don't need more sedation. This was a completely normal person. You could have them intubated if you had their pain controlled with no sedation because it's a normal person. So if they are raving, if they're trying to pull their tube out and miserable, it's not because they need more sedation. The reason that patient would be agitated once you take pain out, there is none. The reason they're agitated is because they're in horrible discomfort from a tube caused. Hey folks, we're just going to stop for a second because this is a free episode. I'm giving it to you in its entirety, but it's very rare that we have these full free episodes because EMCrit is a members-only site that still has foam. But if you're enjoying this content, please consider becoming an EMCrit team member. It's inexpensive. You get CME. You could write it off on your taxes, but forget all that. What it's going to do is make you the best possible resuscitation and critical care doctor you could be. You'll have the most cutting-edge, up-to-date information, and you will get it in the comfort of your car or on the subway or while running. And you'll never have to think, am I current enough or not? Am I taking the best care of my critically ill patients? All right, let's get back to the show. A constant gag reflex and causing incredible discomfort. If you control that patient's pain, you'd be back to the point where they need no propofol. And that's what you really should be going for, is the pain is controlled and the propofol is just a little bonus on top for a patient who was normal beforehand. And I don't think that gets recognized enough, is that the patient is not trying to make your life miserable by pulling the tube out. It's their only way of expressing, I am in horrible pain here. And those patients oftentimes get snowed on propofol unnecessarily. That promotes delirium. So you want to have this good baseline pain treatment first. I'm not saying the order of the meds, we're going to start them simultaneously, but in terms of conceptualization, pain first and then deal with agitation once the pain's controlled. And that requires usually more pain meds than people are willing to give, especially in morphine shops. Because I see these orders of 4 milligrams of morphine, which is not even a good starting dose, and it's not going to get them there. It's one of the reasons you and I both like hydromorphone, is if you give a milligram of hydromorphone, which doesn't seem like a lot, you get them usually at a good starting place in terms of their pain. So what would be your requested starting dose for a patient in hydromorphone and then in morphine if you were in a different shop, Candace?
I would stick to the 1 milligram of hydromorphone, and I'd go with 8 to 10 milligrams of morphine.
That's where I'd be as well. That's perfect. Yeah, and if you really wanted to quantify that, like 0.1 milligrams per kilogram will get you in that same range. That'll give you that 7 or 8 of morphine where you want. The hydromorphone, 1 milligrams where we start on almost every patient. Maybe a super frail geriatric, we go 0.5, but usually they're intubated. What are you worried about? Just give them 1 milligram. And then what we implemented when you and I were together that was game-changing was a pain titration order that allowed the nurses to assess every hour using a scale. It was the CPOT scale, and we'll put that in the show notes. And they now had the power to just give the patient another 0.5 milligrams every hour if they felt they needed it, rather than having to go get a doc. And that's just game changing. And are nurses still using that same titration protocol, Candace?
It depends on the doc. Some docs will use it and some will not. I think that some people have started with a little bit of a fentanyl continuous drip as an option to make sure that they're comfortable with the fact that the patient's receiving continuous pain medication in addition to their sedation. So I think that's an option. And maybe for us, because we stock that in the Pyxis, right? So when I choose 8 milligrams of morphine, I'm a nurse, right? So I know it comes in my shop in 4 milligram doses. So I would take 8 milligrams or 10 milligram vial, right? 7 to me means I have to waste,
Yeah.
right? I don't want to do that.
I love it.
One, I don't want to throw it away. And two, it's inconvenient.
Yeah, so you got to train your doctors gently to say, hey, when you order 7, don't do that. Order 8. It makes our life easier.
Yeah, or I just take away the orders for 5 and 2 and make them 4, 8, and 10.
There you go. I love that. Now, I don't particularly like fentanyl drips. And if you're doing it in the emergency department for those first few hours, it's fine. But there's 2 problems that come of it in my mind. One is if they're on a fentanyl drip, then there's no longer really titration when it's too much. They'll titrate when it's not enough, but too much, it's like, oh, everyone's happy now. The patient's just chilling out. And you could get a real accumulation of these meds, especially if the intern overnight in the ICU is just going to be continuing whatever the ED starts. So I don't like it from that perspective. The other perspective is when the patient doesn't have enough, nurses have a tendency, in my experience, to just up-titrate the drip. And that takes a long time to get that patient out of pain. They're not going to have that immediate response. What ideally would happen is every time there's an up titration, there's a bolus of the fentanyl given as well. But because, like I said, that long-term accumulation, I would much rather just see the nurses going in every hour and deciding, does the patient need more pain meds? And so letting them have the power through a standing order that just says, here's my CPOT goal, and give as much intermittent doses of hydromorphone or morphine that you feel the patient needs. That's, in my mind, the best system. Now, you show me a patient with high ICP and what have you, where the opioid is really serving secondary purpose, then fine. Like, I'll start fentanyl drips on my head injury patients. That's fine. Post-cardiac arrest hypothermia, same thing, right? Like, these drips are serving other purposes. It's now for shivering prevention and what have you. But for my regular intubated patients, I would much rather intermittent pain meds and continuous sedation meds.
I think it gives that balance, right? Like, then you give me the autonomy to make the decision. And I think that's where people struggle, right? So you have to know your team and know who you're working with. I think that in that regard, I'm incredibly spoiled, right? I only work with certain people, but, and those people would have a trust with me and know that I'm not gonna, not give pain medication. And I'm continuously documenting my CPAT. I think that's also important so that you can see what my impression is, right? Because maybe we don't have the same impression and we need to get to the same level. But I think that's where the fear is in the people. And believe it or not, those that start the continuous fentanyl drips are the ICU team that has their patient boarding in the ED, right? So maybe it's because their relationship with the ED nurse isn't the same as the relationship between the ED nurse and their ED attending. That, like, I always felt like my success was based on how well I worked with the person. Now, we don't have to be best friends, but we have to work together.
Absolutely. And maybe the ICU just doesn't know which individual ED nurse they're going to get. With the traveler situation in most emergency departments, it might just be, hey, if I put them on a fentanyl drip, I know they're going to get some opioids, even if it's not ever going to be titrated, versus if I just leave it up to the nurse. I don't know. That nurse may never have worked in this institution before. They might have come from a place where they're just using high doses of propofol. So maybe that's what it is. It's why, and we'll talk about this in a future show, I think having standard operating procedures is incredibly important, and then communicating them to your ICU of saying, like, this is the way we train our nurses, and they understand, they have a protocol for intermittent pain medication after sedation, will help maybe build that trust at a greater level. All right, Candace, there's 2 more things I want to talk about on this topic, and then we'll go to whatever else you want to add. But one is, you mentioned that nurses sometimes, if they have not really made this knowledge acquisition will turn off the propofol when a patient gets hemodynamically unstable. And you mentioned, well, they should just grab a medication for blood pressure. And I would urge that at the same time you're getting those meds for post-intubation sedation, you just ask the doctors, if they haven't realized this themselves, hey, could I also have an order for a norepinephrine drip? And what I'd love to see at every bedside of every intubated patient is a norepi drip on a pump just sitting there, ready to go. They will almost inevitably become hypotensive at some point. And if you have a standing order saying MAP less than 65, start norepinephrine, now you don't need to turn down the propofol that you have worked so hard to get a perfectly sedated patient on, because it's not the same thing when you turn it back on. That patient now has a period of misery. It's going to take a lot of work to get them back to that nice, relaxed state. It doesn't just go away when you turn them off and then turn them back on. So that's what I'd like to see, is the reflex action of a patient with a MAP that drops after intubation is not turn down the sedation, not stop the pain medication. It's turn on the norepi that's already at the bedside. What do you think about that, Candace?
I think that makes perfectly good sense. And I think that you can go pretty low after you turn on your norepinephrine drip. You can go super low so that you didn't shut it off and you titrated it appropriately, right? Because then if you shut it off, then you need another order to restart it, right? Those are those Joint Commission rules that nobody likes. So you could leave it pretty low before you never really shut it off, and then you could use it to your own advantage, right? And I think that making sure that you're clear in the decision making that you're having, I always say to people, if you did something that I would not have done, if you had a thought that was reasonable around what you did, I can wrap myself around that, even if it wasn't something that I would have done.
I love it. You mentioned some like really important tacit knowledge there, which is if it gets turned off, you can't turn it back on. We'll hear these people say, in my shop, we can't have standing orders. We can't just say, if that's fine. The mark of a good resus nurse is they are not dealing with the situation in front of them solely. They're also prepared for situation X, Y, and Z that might come from it. And you start learning which situations are going to naturally occur quite commonly after whatever you're dealing with. So any research nurse worth their salt knows if I have an intubated patient, they're going to get hypotensive. It should just be planned for. And if you're in a shop where you can't get that order standing to start it, that's okay. What you want to do is you want to still get the norepinephrine out of the Pyxis. It's not a controlled medication. Still have it set up on a pump. And then you could just say to the doc, hey, I'm starting norepi. Could you put an order in? And then you don't need a standing order. Or what happens in most places, and we're not going to discuss this with the Joint Commission, is a good resus nurse will start the norepi if the MAP is 45 and then say to the doc, hey, put the order in. And it's not, can I get an order? It's, hey, put the order in for the norepi. I had to start it. That's where I'd like to see resus nurses getting to, is the point where they are proactive. And look, on paper, nurses can't tell doc orders. But in real life, if they're not doing it, those patients are suffering. Critical care at the bedside is started by nursing and then pushed to the doctors versus vice versa. If you're in a place where the doctors are the initiation of things that need to be done immediately on those patients are not getting good care. Have I said anything that's untoward, Candace?
No, I think you're 100% right. Like I think that I spend more time at the bedside than you do, right? Because there's opportunity for you to take care of 25 people and for me to take care of 4. So it's a huge difference. And I think that you are one person, right? And you cannot be in 5 places at one time. So you really rely on your nursing partner to help you see the parts that you're missing. And that means that I operate to the top of my license. And I think that's what we strive for, is ensuring that the nurse operates at the top of their license, meaning that if I find that the patient's hypotensive, I will start a drip. Standing orders in the sense of you can't just say, oh, you have chest pain, so I'm going to have all aspirin, fentanyl, morphine, whatever drugs you want to give, nitro, all there, right? But I do think that standing orders for vasoactive drips, whatever your choice is, as long as it has parameters, that's not really a standing order. It's an order that's titratable. So you can't just leave it blank. You need to give some direction, whether that is a MAP less than 65 or you're putting sedation orders there with a RAS between -1 and -2, whatever your choice is. But you can't just put something up there without a directive. That's the problem with some, especially New York State, right? We have no nurse orderables in the state. It's terrible. But there's plenty of places where they have a tremendous amount of them and their autonomy is so much greater. But that doesn't mean that those of us that don't have those nurse orderables shouldn't function to the top of our license, because we absolutely should. And I agree with you. So whether it's that you put the norepinephrine drip in, which is optimal that you do that at the time that you're closing out the intubation, so that when you do have that period of hypotension that's a little bit longer than you would like it to be, you gave that nurse the autonomy to start that. Or we work in a place where I just said, I did this, and I did this because of this. I started norepinephrine because I had a MAP of 45 and it was pretty sustained for 3 to 5 minutes. So I put the patient on a norepi drip and can you put my order in, right? And usually that's the trust factor that you need to build with your group. So, as much as this is teaching people about how we take care of patients, it's also about those personal dynamics, right? And you being comfortable and confident. As I said earlier, if you have to prepare for something, then you're never prepared, right? You should always be prepared to the top of your ability. And I think that includes things like this, right? Like if we were intubating somebody, I would just say, oh, we're going to intubate this person. What are we going with? Rock and etomidate or ketamine. What are we going with? You just pick what you want. I got the rest of the stuff. You don't have to ask me for it. I already know what I need. Right. And then there's that balance there. And I think that's safer for patients. It builds trust between the providers and it overall produces a better outcome.
100%. And if you're a doc listening to this, or, if you're a nurse and you have a doc like this, play this for them. If you're a doc who a nurse comes to you and says, the patient was hypotensive after intubation, so I started up the norepi, could you put an order in? And you yell at them and say, I don't like norepi, I like dopamine or phenylephrine or whatever, you're a piece of crap, because you have now taken a nurse who this might have been a budding action of autonomy, and they are really nervous. They took an action on their own that actually saved that patient's kidneys, because even short periods of hypotension are bad. And they did what was right. And if you wanted another drug, fine. First, you congratulate them. Thank you so much. That was excellent. You actually did just the right thing. Do you mind if we transition after a little while to blank? Now, I don't know why you'd want to transition to any other med. Norepi should be the starting point for anything. But let's just pretend. Don't ever nip that autonomy in the bud. You want to develop autonomy in your resus nurses. If you're not looking for autonomy in your resus nurses, then you're not going to have a good resuscitation shop.
Yeah, you're not, because the reality is you get more than one patient that requires resuscitation and you can't be in more than one place. So oftentimes we'd get 2-3 patients at the same time. And I would tell you, I'm going to go see that person. I'll be back if I need you. Right. And you never had to worry about that. I think that's what you should strive in your shop, is to have that kind of collaboration with your team to say, I think you're good here. I'm going to go see this new person, or to have your strongest partner say, I'm going to go down there while you put this tube in. If anything, I'll come back and get you, but otherwise I'll get it started.
Absolutely.
And I think that's really where you need to get. It makes your whole shift dramatically different when you have that kind of budding relationship.
Love it. All right, the last topic, Candace, is one that I've been sad about, and you could tell me if this is a state thing or a nationwide thing, but there was this real sea change that we could not use soft wrist restraints on our intubated patients anymore without like an insane amount of documentation and a one-to-one sitter. And so now, the only way to successfully deal with that in most places is to just not use wrist restraints anymore. And those wrist restraints weren't this horrible act of evil bondage. These are patients who, had soft restraints on their wrists. They were really just there to remind them, hey, don't pull out that tube. If they really wanted to get out of them, they could. But they were this, I think, very helpful way to avoid extubation. And if you are going to be leaving patients light, which is the best thing for the patient, then, there's going to be an increase in extubation rates. And I've seen many EDs, the way they deal with it is they're sinking these patients down into a coma to avoid extubation. Why is this happening, and who thought this was a good idea?
Well, I don't believe it was the nurse that thought that was a good idea. That would be a regulatory agency that thought that was a good idea.
Was
Yes,
it national
you are
or
correct.
state?
No, it's national.
Oh, God. Okay.
I think that there is a tremendous amount of documentation associated with restraints, whether it's violent or nonviolent. I think we've started the mitts before wrists campaign, right? So if you put the mitts on the patient and you don't tie them, we actually cut the strings off. So there's never an opportunity for them to be tied. The person can't grab at their tube, right? And it keeps them from pulling out anything. I think you have that opportunity. I think that there was some skin damage if it was kept long term, but I think it all goes back to the same thing. You're not properly dosing the patient for pain and sedation. So once you figure that out, not sure that you need the restraints. But if you're going to need something, and obviously this is very different than like the extremely agitated, maybe somebody on some street drugs kind of person, right? Not talking about that, but you can certainly do the mitts before wrists. I think your hospital or organization will like that better, right? Because one, it doesn't allow them to really grab at that tube if you put the mitt on correctly. We do cut the part off that would secure it to the bed. So there's never an opportunity that it gets secured to the bed, and it would prevent any kind of skin breakdown or vascular compromise if you tied it too tight. I think that they have a fear of that restraints cause harm. I think that they're used in the right setting. They don't cause harm, exactly like what you said, but sometimes less is more. And people would use them for reasons that they didn't need to. And then it got to this kind of process where people would just use them all the time, even when it wasn't needed. So then when the patients that actually did need it, you didn't have that as a luxury. It now became like a real pain in the ass to order wrist restraints. And then you're right. Then it does definitely put them in a super deep sedation because people just don't want them to pull out their lines or pull out their tubes. So we do mitts before wrists now and put the mitts on for that specific subset of patients where we can't seem to find a happy median. I think most of the time we're underdosing their pain medication. And if we use, when we use the CPOT, you don't find that you need that at all. Versus the patients that the doc isn't really, a huge fan of the CPOT. I think that's because they're unfamiliar with it or they didn't work on their relationships with their nursing team members.
Candace, what have we missed that we should hit before we say goodbye?
I think that when you're finished with whatever procedure you're doing, so if that is an intubation at the end, you should say, how did you think that went? There's always an opportunity to talk about what you think could have been done differently from the nursing standpoint.
Yeah, I love that. I think a conversation after every intubation, especially with a traveler or a new nurse in which the doc and nurse come together and run through some scenarios. And then you can actually say, hey, if this patient becomes hypotensive, just use the norepi. Don't have any qualms about that. You don't have to lower the sedation. Now we're establishing a shared mental model for going forward. All right. Candace, I really enjoyed this episode. Thank you so much for your brilliance as always. And I will tell the folks goodbye, and then you say whatever you want to end off with, Candace.
I think that, if I leave you with anything every time we're done, is that this is really about what we can do together rather than what I could do alone and what you can do alone. I am only as good as I am because of you, and you certainly are only as good as you are because of me.
Damn straight. All right, perfect place to leave it. Bye-bye, everyone. We'll talk to you next time. Okay, now is the time. Go to emcrit.org/contact. That is emcrit.org/contact. And let me know how you liked the episode, how you liked the depth of the episode, how you liked any part of it, how you like the project in general, what you'd like to see changed, good or bad. I am so open to any criticism. Please, please, please just go to emcrit.org/contact and let me know. Thank you. Bye-bye.